Afternoon. Welcome to the online Master of Public Health Programs Spotlight webinar, Working Through COVID-19 presented by the Keck School of Medicine at the University of Southern California. My name is Kiana Carter. I'm a graduate admissions advisor with the Master of Public Health online program, and I will be your host. I would like to thank you for taking time out of your busy schedule to join us today. Now, before we begin, I want to review what you can expect during this presentation. First, if you have any questions, please type them in the Q&A box located at the bottom of your screen and hit send. Feel free to ask your questions as you think of them, and we will answer as many as time allows at the end of the presentation. A copy of this recording and slideshow presentation will be available shortly after. Now, I will give a brief overview about the Keck School of Medicine and the Department of Preventive Medicine and introduce our speakers, Dr. Pavana Varanasi and Megan Kinney, MPH. Then we will hear from our guests who will speak to their experiences working during the COVID-19 pandemic. Lastly, we will end the presentation with that brief Q&A session. Now, the Keck School of Medicine was established in 1885. It is the oldest medical school in Southern California, and today it is a place of dynamic activity in patient care, scientific discovery, medical and bioscience education, and community service. Together, we are poised to lead medicine and healthcare in the 21st century for the benefit of humankind. The Department of Preventive Medicine at the Keck School of Medicine of USC is known as a leader in public health and population health sciences. It's organized into 6 divisions: disease prevention and global health, bioinformatics, biostatistics, cancer epidemiology and genetics, environmental health, and health behavior research. Now, the Master of Public Health online program offers a rigorous curriculum that attracts dedicated and ambitious professionals with the passion to serve in the public health arena. There are 6 different concentrations that students can choose from when pursuing this degree. They include biostatistics and epidemiology, community health education and promotion, geohealth, global health, health sciences and health services and policy, and a generalist concentration. Now, today we'll be hearing from 2 of our students. Dr. Pavana Varanasi is in her first semester of the online Master of Public Health program here at USC. She hopes to utilize the intersection of her MD and MPH to increase access to healthcare and optimize healthcare delivery systems. She earned her Bachelor of Science in Neuroscience with a minor in Biomedical Research from UCLA in 2015, and her MD from Ross University School of Medicine in 2019. Earlier this year, Pavana served as a medical volunteer during the COVID-19 pandemic in New York and is now starting her residency in internal medicine. Megan Kinney, MPH, currently serves as the health educator for the Santa Barbara County Public Health Department's Tobacco Prevention Program. Her goal has always been to improve the health of her greater community. After receiving a Bachelor in Kinesiology in 2017, Megan decided to pursue an MPH degree with USC's online MPH program and graduated in August of 2019 with a concentration in community health promotion. Megan was called to serve as an emergency service worker on the COVID-19 response and was responsible for managing all COVID test results for individuals throughout the county. We are so excited to have them join us today. So let us begin. Hello, Pavana. Thank you for joining us today.
Hi, thanks for that great introduction. So I just want to start off by saying that this is just like my own personal experience, and I'm not speaking for any hospital or anyone else's experience doing this volunteer work. And with COVID in general, everyone I think that I've talked to has had a very personal experience in the kind of personal, the emotional fallout and all of that they went through dealing with COVID. So a little bit of background about how I kind of got into this. I basically served as a medical volunteer during the pandemic, and I really started at the peak of the pandemic in New York City. And there were quite a few ways that I know I had friends that joined in New York for a similar relationship. And a lot of people did New York Med Corps, where nurses, doctors, other healthcare professionals were quote unquote deployed to hospitals that needed the extra staff. On the other hand, I actually got my position directly dealing with the hospital that I worked at. So I worked with the internal medicine resident team, and I provided them with support, really an extra set of hands while they handled a crisis where an extra set of hands really meant a lot. It was kind of priceless. And the hospital was short-handed and short-staffed because, the staff were getting sick slowly but surely, and then definitely short on supplies. And I was lucky in the sense that our hospital and the administration really handled COVID in a way such that we were never concerned about not having PPE or not having masks or gloves or anything like that. Anything to protect ourselves or to do our work properly and with patient safety in mind. A little bit of background about COVID and the Bronx, where I was based. So about 29% of the population here lives below the poverty level, and that lends to an increased prevalence of uncontrolled medical conditions like diabetes, hypertension, smoking, obesity, cardiovascular diseases. And there are also increased psychosocial stressors in terms of homelessness and lower educational levels. Immigration problems are pretty common here. A low socioeconomic status as a community, really, and then that lends to difficult access to healthcare. And this leads us into talking about what happened during COVID, because the urban implications of the pandemic is very important in this community where, when it's an urban setting and everyone's kind of in such close quarters, how do you really social distance, and how do you stay home when your family can't necessarily afford it, and all these other implications that, generally the community in other boroughs where the socioeconomic status is higher was not really that big of a consideration. Of course, it was a consideration for many, but in this borough especially, it was a very difficult thing for people to navigate. So just to get us started on the actual COVID statistics itself. So this is a graph from the New York Department of Public Health website. And here we can see in the blue are the number of people tested in general in New York per day. And overlaid onto the blue is in the yellow is the number of people that tested positive of the people that were tested. So the day I have highlighted there, it's a little small, is on April 9th, which is about mid-peak in that pandemic. That's right around the time that I started. And as you can see, over the course of time now, towards the end of the graph, we can see that the number of positive results per population tested has greatly decreased. And we can say, unlike many of the states, unfortunately now, but New York has really seen a great decline in the cases, and the curve has declined. So this is, I guess now, I think Kiana was saying earlier that New York is now the model state, and it is, and it was very hard, and we finally got here, but it took a lot of work. And I think that's what a lot of the other states, like, we're kind of complacent in a sense at the very beginning, and now are paying the very unfortunate price of increased cases, which will lead to increased deaths. To understand the depth of the crisis, I guess, in a hospital where we have an approximate average of 30 to 40 patients on a ventilator or life support, during COVID, that number doubled or almost tripled. And there were an estimated 50 to 60 new COVID patients being admitted every single day during the peak of the crisis, that is. And the thing to consider when the number of critical patients increase in such a dramatic way like this is, where do we put the patients? That's a very big consideration, because operating rooms, procedure rooms, became essentially pseudo ICUs, because there's just so many patients that needed this kind of critical care. And the sheer number of admissions was just overwhelming. And that, of course, leads to increased lab work, increased hourly monitoring, and talking to families and contacting them regarding essentially daily updates. And even more than, the quote unquote normal, families, of course, are very concerned about their loved ones, because this was like a new pandemic. This wasn't just, heart failure or a smoking problem or a drug overdose that just, that for them, they had kind of, in a way, gotten used to, because it was their loved one's medical problem. But now is this new kind of fear that's unknown. And of course, this all led to an increased number of daily deaths, which is, from an emotional standpoint, is very draining. So in fact, the burden in New York City was so high that Javits Center, which is a convention center here, was actually converted into a makeshift hospital. And it was staffed by, I believe, the doctors from the US military service. And just apart from the workload, I wanted to touch on the emotional fallout. Oh, just a note, the picture at the bottom is a picture of the beds at the Javits Center. And but so back to the emotional fallout. And so this, we're looking at both for healthcare workers and for the families. So in terms of healthcare workers, I think most of us in general, you can say, go into this career for very altruistic reasons, help humanity, save lives, etc. But when the pandemic hit, there were just a sheer number of cases, something unlike anyone had really ever imagined. And you're doing kind of everything you can think of, everything medicine trains you to do. And there are just some people you just can't save. And, as always, you always know that there are going to be deaths in this career, and you're going to, have a front row seat to that. But at the same time, seeing so many people go through this every single day, or seeing people that you wouldn't normally anticipate would become so critical go through this, is very daunting. And it's a hard weight to carry. And I know that now there's even more attention being brought to physician stress and burnout, and really suicide as well. And during the pandemic, there's definitely an increase in these numbers. In terms of the families, it was also very difficult, because the families have this lost memory of the patient, because visitation was suspended during this time. So their last memory is of the patient being well. So they cannot comprehend the decline that the patients go through. And it was very difficult for us to explain, because how much can we really tell them over the phone, and it's such a hard conversation to have. And honestly, you don't want to accept the fact that the patient isn't doing well any more than the family member does. And so many times we heard, family members repeatedly saying, but how? I don't understand. The patient was just dancing 2 weeks ago before he went to the hospital. There's just no way that the patient is, at this clinical status right now. So our hospital actually got iPads for every single floor, so that if the families had iPhone, FaceTime capable devices, then we could go ahead and have them see the patient, so that at least then, they have a mental picture of the patient. And then, in addition, even for the patient, it's been proven that family and social support really help outcomes and reduce recovery times. And so it was kind of a double-pronged effect for that. So in terms of our current, the current trends of COVID, so here on this graph, it's this is from The Economist, but it's based on Johns Hopkins data. We see that New York City, but as I mentioned before, is now on this decline. The curve has come down in comparison to the rest of the country, where the cases are, as we know in the news every single day, cases are going up. So in terms of my hospital, we're down to about probably 2 to 3 COVID admissions a day. I'm not really hearing about too many. I'm not seeing too many. And probably less than 10% of the patients in the ICU are COVID positive. And in that sense, we've now come back down to our COVID average of the number of critical patients we have. And they're not critical necessarily because of COVID, mostly because of their own, like their other issues, underlying medical problems. Just at the peak, though, New York State as a general actually made up about more than 25% really in the national cases and deaths. And now we've become one of the lowest in cases, hospitalizations, and deaths. So just to kind of wrap up, I just want to talk about what I think the public health and patient care intersection is. So they really do coexist in terms of healthcare. And I am pursuing this MPH because I really believe in preventative health and in health promotion projects and increasing health literacy. And I think this is such a big deal for lower income and lower educated communities, especially, with an increase in preventative health, then, ideally and theoretically, both we would be decreasing the amount of progressive sequelae that we would see in their medical problems. And I think it's such an important aspect of healthcare, even as a medical doctor, it's so important to talk to patients and tell them, these are the ways you could prevent, these are what you can do to maintain your status of health now, and information that a lot of people don't have access to, unfortunately. So this is just to wrap up. On the left is my picture from my medical school graduation last year. And then on the right is me, a very different picture, really. I'm donned in my PPE from head to toe. So I'm wearing this spacesuit, jumpsuit-esque thing with a hood. Under the hood, I have a hairnet on and then a full face shield. It's a plastic shield. An N95 mask. I'm double gloved, though I don't think in this picture, and wearing booties. And this was basically 12 to 13 hours a day. We wore this get up. We also had an extra gown that we would put on when we went into different patient rooms. So it was a lot, and it was very difficult, but I'm very thankful that I was able to, help in any way that I could. And it was really an experience of a lifetime, and I'm glad I'm here to talk to you guys about this. So I want to pass it along to Megan now.
Hello. Thank you, Pavana. It's really amazing and eye-opening to hear your experience working on the front lines as a physician. And I can't say this enough, but our frontline healthcare workers deserve so much appreciation for what they're doing. So thank you. And thank you to the Master of Public Health Online program. It was this time last year I was actually finishing up my last semester in the program and attending these webinars, listening to alumni speak. So it's kind of surreal to be speaking today, but I'm here to share my experience working on COVID from the public health side of things, more specifically at a local public health department. And I'm really hoping to share my experience kind of as a snapshot of what so many people are doing right now and share on behalf of everyone who's contributing to this tremendous public health effort. But I'll just kind of mirror what Pavana was saying in that this was my experience. And so I will defer back to just speaking for myself and what I went through. So I will quickly start by explaining how I got to where I am now. In undergrad, I originally intended to go into physical therapy, and so I chose to study kinesiology And I worked in physical therapy clinics for several years, but it wasn't until my senior year that I was introduced to public health. And with my degree in kinesiology, we learned so much, not just about injury prevention, but about disease prevention through healthy eating and active living. And while I loved working hands-on with people, I became really interested in preventative medicine as a whole and how it could be implemented on a community and population level. So it was shortly after I graduated in 2017 that I came across the National Commission for Health Education Credentialing website, or NCHEC. And I learned more about what the job duties of a health educator are. And I remember thinking to myself, this is exactly what I want to do. So while I originally intended to take a year off before starting any type of graduate program, I hadn't really decided at that time, I came across USC's Online MPH and was instantly convinced that this is where I wanted to go. It was close enough to me that I could visit campus for conferences and events, but I could also live at home with my mom for free and work while getting my degree. And on top of that, what drew me in really was looking at the curriculum, seeing the amazing professors, the opportunities that they had, and hearing other people's experiences. So I applied the fall after I graduated, and I started the program in January of 2018 with a concentration in community health promotion. And I absolutely loved my experience in the program, and I learned a lot. I feel so grateful to have the opportunity, the ability to get a graduate degree in a field that I'm really passionate about. And I was also lucky enough to be selected to give the commencement speech, so that made the completion of the program extra special for me. And I sat on stage and spoke just before Dr. Barbara Fair, who I really look up to. So it was truly an amazing experience conducting that. An important part of my story, kind of moving on, and how I got to be where I am right now, is where I completed my practicum. So knowing that I wanted to become a health educator, I wanted to find a practicum working directly with a health educator at a public health department. So I searched the Santa Barbara County Public Health Department's website, and I came across the contact information for the program coordinator of the Nutrition Education and Obesity Prevention Program. And given my background in kinesiology, I was and I still am very interested in nutrition and exercise. So I emailed her, and it probably took me about 3 emails before she responded to me, but she did, and she referred me to the newly formed local oral health program. And I contacted them, and I was lucky enough to be hired for my practicum. So I worked directly with the health educator as well as with the program coordinator. It was just a little 3-person team. So Proposition 56 is a tobacco tax, and some of the money goes towards funding local oral health programs. In Santa Barbara County, the oral health funds had previously been allocated to the Office of Education, but the Public Health Department had recently acquired that funding just several months before I joined. So it was a brand new program at the Public Health Department. And I feel so grateful for this opportunity because I really kind of jumped headfirst into a lot of normal health educator tasks like community education. I created a social media campaign in English and Spanish for National Children's Dental Health Month. I assisted with 2 of our oral health related coalitions throughout the county. And I helped with some of the important state deliverables. Because we were a new program, we were required to submit community health needs assessment and then use that information to inform a community health improvement. So I was able to work with a lot of the data collected for the needs assessment and then wrote a good chunk of that report, as well as a health improvement plan, which might not have been an opportunity if I had joined a program that had been established at the Public Health Department for some years. So applying the skills I was learning in the MPH program at that time in kind of real life scenarios, it not only helped me to solidify what I was doing, but it was really rewarding to me. And I kind of learned that this was what I wanted to do. And again, this is kind of an important part of my journey because shortly after I reached my 300 hours for my practicum, I was hired by the HIV/AIDS program for a limited duration health educator position, working on a special project. So for 3 months, I was tasked with educating the county's emergency departments, urgent cares, and community clinics on the CDC's routine opt-out HIV testing protocol, which was an awesome way for me to get to know the healthcare community in Santa Barbara County, but also use my cold calling skills trying to schedule appointments with various medical directors. So once that position ended, I was very lucky again that a full-time health educator position opened up at the public health department with the tobacco prevention program. And I applied and I got the job, and here I am now. I never thought I would work in tobacco, but I really and truly absolutely love it. The tobacco prevention program works to educate the community about the harmful effects of tobacco. We advocate for tobacco control, and then we assist with policy development. And the program, again, is funded using Prop 56 money as well as Prop 99, which are both tobacco taxes, under the direction of the California Tobacco Control Program, or CTCP. So going back to my original perceptions of public health, I wanted to work in chronic disease prevention and really only understood what that looked like at kind of a community or organizational level. But in the MPH program, I was introduced to the social ecological model and learned how prevention could be achieved through policy work and systems change. And I feel very grateful now to be gaining experience working on this level. So as I mentioned, much of what we do is policy work, and these are just a few images of our program and our coalition members advocating for tobacco control at local public policy meetings. Most recently in the county, we've been focused on banning the sale of flavored tobacco products, and then at the same time, we use this as an opportunity to set up tobacco retail licensing as a means of enforcement. We create minimum pack and price restrictions and ban the use of coupons, discounts, and deals. And the flavor bans don't just target vaping products. We target flavored cigarillos, cigars, chewing tobacco, and especially menthol cigarettes. I still find it hard to believe that this time 3 years ago in midsummer, July, I was looking at the NCHEC website, reading about health educator job functions. And I myself now am working as health educator, but the health educator position with the tobacco prevention program kind of hits a lot of the standard competencies of a health educator outlined by NCHEC. First, there's a lot of community education through various mediums. So I help manage both our paid media, which is print, social media, and radio, as well as our earned media. So working on press releases and doing interviews. There are a lot of presentations to the community, which I love doing, as well as creating educational materials. And with our recent flavor bans I've had to do a lot of outreach and education to our tobacco retailers located in the county. It's been a very interesting experience working with this population because our policy work is essentially taking away their business. And I can't say they're huge fans of me when I walk into their shop with a pamphlet of all the products they can no longer sell, and understandably so. But I've learned that it's really not our jobs to be an authoritative enforcement figure with them, but really we need to learn to work together with these retailers. And I got very used to owners and managers just voicing their opinions and concerns about these ordinances for, up to 30 minutes at each visit. And although we come from two very opposite ends of the spectrum, I try to put myself in their shoes and be as understanding as possible, and at the same time while still being firm, and that these individuals are selling the #1 cause of preventable death and disease in the United States to make a profit. So what I've told many of them is that if you have the determination to open a small business once, you can do it again. Just try to sell products that benefit the community rather than hurt it. So a sandwich shop, coffee shop, beauty shop, whatever. We'll see if any of their business models turn around. But it's been a really unique and rewarding experience to work with this population. And as I've said multiple times now, so much of our focus and our directive from the state is on policy work. So this is the systems level change that trickles down to the individual level. By making flavored tobacco unavailable, our goal is to decrease initiation rates among youth in our community. And with policy work, the health educator is involved in convening task force meetings, providing technical assistance to elected officials and staff. And we usually do this in collaboration with the Public Health Law Center because I, for one, am not well-versed in legal language or the law. And then we present a lot at public policy meetings. And because we're funded through CTCP and through propositions, we are not able to lobby, which means that we really work to inform and educate and provide technical assistance, but that's kind of where we stop. And then on the other hand, we mobilize the community who does all of the advocacy work. And this is accomplished through coalition building, training, educating, providing technical assistance to coalitions, communities, which is something that, I really spent a lot of time learning about in the MPH program and find extremely valuable now to know this. So on top of all of the awesome responsibilities of a health educator, as a public health department employee and just a public employee in general, I am also a disaster service worker under California Government Code. So this means that during an emergency, I must help maintain essential services at the public health department or serve potentially in a different capacity to assist with disaster response. So FEMA has a very detailed response protocol called the Incident Command System for Healthcare Emergency Response, or ICS, which is a part of the National Incident Management Systems. And I found it interesting, ICS was actually developed in the 1970s following a lot of the terrible fires that were happening in California, and it's still used today. So when the ICS is activated, EMS, Emergency Medical Services, and designated health department or any public employees assume new roles in each of these kind of 5 functional areas throughout the ICS, either command, operations, planning, logistics, or finance and administration. And the actual physical location where everyone meets is referred to as the DOC, or a Departmental Operations Center, or if it's kind of more of a collective, not just within one department, such as the Public Health Department. If it's kind of a county-wide effort at this point, it's referred to as the Emergency Operations Center. And lastly, another component of the ICS is the JIC, or the Joint Information Center, which coordinates all of the incident-related public health information, PIO activities. And the JIC is usually where health educators would report during emergencies, kind of given our background in health communication and understanding of health literacy. So my supervisor, who's been at the Public Health Department for several years, held a predetermined position in the DOC within the JIC. So she was called rather early to begin helping with the response. And it was a few short weeks later, in March, I was asked to report to the DOC to assist with the epidemiology unit. And again, normally a health educator might focus on public information activities, but we already had many of those roles filled, and the pandemic kind of posed a lot of new challenges and required a different kind of response than we might be used to here in Santa Barbara. And I would imagine so many other public health departments kind of face this same challenge. So it was really my MPH that allowed me to serve in the EPI unit, because although my concentration was in community health promotion and health education, I took an epidemiology class and I practiced and applied it in many of my other classes. So I'm grateful that I had that background. I reported to the DOC in March, as I said, and I assisted the EPI unit for like 2 to 3 days, kind of helping with data entry and not really understanding kind of what was going on because it was so busy and everyone was kind of crunched for time. But I think it was my 4th day, we were called into a meeting and I was told that the EPI unit was restructuring to have kind of 3 branches, as I laid out here on this slide, and which are surveillance, cases, and outbreaks, and that I was being assigned as the surveillance lead. So as the surveillance lead and as the surveillance unit or branch, we had 3 responsibilities, and we were to manage and organize COVID-19 and then later, last several weeks, antibody testing data for residents throughout the county. We needed to maintain a database of test results for the use of our disease containment unit and their contact tracing efforts, and then report daily negative, positive, and inconclusive testing numbers. And all of this information was published on the daily status reports released by the department to the public. And over time, these numbers were used in calculating positivity rates throughout the county. And I had an awesome team of other public employees who helped with these tasks because I could not have done it alone on a daily basis. But to be honest, this was pretty overwhelming and stressful to be kind of in such a crunch every day. As soon as we would get used to the way things were being done, we'd create a solid workflow with, what data we were receiving and how we were managing it. And then I would train everyone on how to kind of follow this new workflow. Things would just change. And I know this is the case. I'm sure this is the case for everyone working on this pandemic. It's really kind of ruthless in that nature. I know that there are thousands of public health workers out there right now solving immense problems that have huge implications, potentially sometimes life or death. And those individuals are probably far too busy to be speaking in a webinar right now. But I have so much kind of respect and deep admiration for our public health workers and our healthcare workers. Despite feeling overwhelmed and stressed, I was so grateful that I was in a safe office where I could appropriately social distance and had access to adequate PPE. And just seeing images of healthcare workers like the one that Pavana showed in layers of PPE, working long shifts in incredibly trying hours, and just think, these individuals definitely are the heroes. So I served as a surveillance lead up until the end of June. And at that point, I transitioned out for two reasons. First, my supervisor of our 3-person tobacco prevention program was going on maternity leave at the end of June. So she needed to train me on how to manage the program while she was gone. And second, I was starting to get really sick. Without even really realizing it, kind of the stress started to exacerbate some health issues that I have. And while I felt energized at work and was happy to give some of my time, kind of the long hours and the stress of the entire situation really started to wear me down to the point where I just was not feeling well and could not perform to the ability that I wanted to. And as much as I hated to admit it, I had to say something and I had to ask for help. And I honestly felt so guilty asking to reduce my hours while everyone was working so hard. But I did kind of hit a breaking point, and I truly wanted so badly just to be able to help, but had to be honest with myself and accept that my body at this point couldn't handle that much stress. So for me, it was an incredible learning and growing experience as a professional, but also as a person. So I'll touch on that more in a sec, but I just wanted to quickly kind of show you a brief snapshot of COVID in Santa Barbara County. Unfortunately, it's not quite the curve that Pavana showed us for New York. You can see that the orange line is the total cases over time. So we've seen a steady upward trend in the past several weeks. But from what I've seen, our community is pretty receptive and respectful of our health officer orders. So I'm hoping that this trend line starts to slope downward soon. On that kind of same note, while I've seen such a tremendous effort among public health nationally, it's been really hard to watch our community almost be torn down a bit by the public and sometimes the media, and as if these health positions aren't difficult enough, to not have the support of the nation sometimes is kind of understandably grounds for making this, significantly more stressful. And I think my hope and wish is that everyone working in public health or healthcare, and honestly all essential or even non-essential jobs, can still practice adequate self-care right now, no matter what that looks like for each individual. These are such trying and difficult times for everyone, and no one alive has really experienced a pandemic of this magnitude, and we're all kind of learning to adapt and cope differently, and it's really not easy for anyone. So with that, I will leave you with my amateur experience, tips, and wisdom as a recently graduated, brand new health educator working in my first public health emergency and first global pandemic. First, I can thank my mom for reminding me that you really can't help others if you don't help yourself first. So just kind of like being on an airplane and having to put your mask on yourself before the people around you. If you're not well, it's really hard to take care of others or perform your job to your normal capacity. And second, all I will say about this is that it's always possible to be kind to everyone, especially in such a stressful time. I know I felt better when I was kind to people and when people were kind to me. And lastly, kind of this quote really resonated with me a lot during my experience, but the strongest thing I ever did was ask for help. And it's really hard to admit that I'm not perfect and I'm not indestructible and I'm human. And sometimes a human that isn't feeling well and has health problems despite wanting to heal everyone else around me. So, my hope is maybe some of you need to hear this right now, but you're not weak for asking for help. In fact, you're very strong. So I hope this information was helpful, and everyone working on the COVID response directly or indirectly, or providing essential services while others work on the response, or to anyone studying public health or thinking about studying public health, I just want to take another opportunity to say thank you. You're making a huge impact at a very important time. So with that, I will turn it back to Kiana. Thank you.
Thank you so much, Megan, for sharing your experience. And yes, Mother knows best. You have to take care of yourself first in order to take care of others. And what the world needs now is love and support. And so we are so grateful for all of our public service workers and the support and care that they provide. So thank you all for your service. And one of our other guests or participants also stated that we're so delighted to hear the firsthand experiences of these young medical professionals in dealing with the public health crisis. And we are especially happy to hear the frontline COVID responses of Dr. Pavana Varanasi. And with that being said, it is now time for us to go into our Q&A session. And so I would like to start that with a question for Pavana. The question is, did hospital social workers work with doctors and nurses on their emotional state, and what resources were made available?
Yeah, so the social workers did not necessarily work with us in that sense. They did continue to provide us support in terms of patient care and disposition as we transition patients out of the hospital. These social workers were also honestly there, especially in our hospital, always busy, always overrun, and even more so during the pandemic, just like any other healthcare worker. Resources, sorry. In terms of resources, the hospital psychiatrists were very helpful. They were very hands-on. They came around very regularly to every single floor to check on everyone and to offer their services, both anonymously and as a group session, basically whatever the individual needed. And there was also a public hotline, I believe it was, that anyone could call if they felt any sort of stress, any sort of burnout, if they just wanted to chat, anything like that. So there was a lot of support out there. I think more of it was trying to figure out or trying to prioritize that. Like Megan said, you have to learn how to do self-care in such a high stress environment, but when you're overrun, how much time do you really have? I don't know. It's kind of a toss-up, but there were resources available is the important thing to note.
Wonderful. Thank you. And as far as the resources that were available, were there resources available to the family members of the patients that were hospitalized due to COVID?
I'm actually unsure about that. There may have been, they just were not as publicized to me, at least. But at the same time, I think a lot of the support that there was going towards the patients themselves, and potentially the family members may have fallen through the cracks a little bit just as a whole. So I'm not sure.
Okay, thank you for sharing that. I have another question for you. The question is, how have you balanced coursework and doing your rotations and working on the COVID pandemic? Any strategies that you can share with, students in the program?
Yeah, I mean, it's definitely been tough. But for me, it's all come down to this very impressive time management that I've been juggling. And I think that's very key in terms of anything that you do, even, outside of school and work. So for me, I have about 1.5 days off a week, and I still have schoolwork to do and I still have classes to go to. So I've kind of become this master juggler, if you will, where, Saturday when I have it off, I'm like, oh, I want to go to brunch, but I have school. So I wake up early and I do school so that I can enjoy the rest of my day, things like that. If I have to study, I have to study, and that's just kind of what it comes down to. And some of it is learning how to, sacrifice more of a social life than I anticipated, I guess. But I'm glad to do it, and I think time management at the end of the day will really conquer all.
All right, thank you so much. This next question actually is from Megan. Megan, did certain staff members step up as mentors in the COVID war room? What are the tips to inspire others in this tense work environment?
Yes, definitely. I think, to me, I look to our senior epidemiologist a lot. It was interesting in that, addressing a global pandemic was new for everyone. And yet I could still look to the individuals who had been around for a lot of public health emergencies, whether in our department or in other departments that they've worked at in the past. And so I'm really lucky in that I truly enjoy all the people that I work with. And if anything, it was so inspiring just to see not only us as a public health department, but us as a county come together. I think we really, we had to work together with kind of our county emergency services as well, because this is a huge kind of united effort. So to me, I look to the more senior employees. They answered all of my questions because I had a lot. And then, through all of this, just seeing a lot of inspiring kind of unity throughout our county and people working together. It's been a pleasure to see.
Wonderful, wonderful. This next question is for you as well, Megan. Are tobacco retailers receptive, or do they have to be monitored after you inform them of illegal products?
I think it varies case by case. I would say that as I started doing a lot of outreach to tobacco retailers, and I would kind of come in, I'd say, here's this informational packet I made. These are all the products you can't sell. And they would kind of, not be super happy with me. They would raise their voice. They would tell me how wrong this is. And then they would start saying things like, this is my livelihood. This is how I feed my family. How could you do this to me? So I learned very quickly, as I kind of mentioned, that it was not my place to kind of be that authoritative voice. We have enforcement officers for that. They can do that. Really, my job was to work together with them and get to know them, honestly, because we, for some jurisdictions, we manage the tobacco retail licenses. So we already communicate with these individuals. So when I started taking that approach, I listened to them. I just would kind of be quiet and I would listen and I'd be like, yeah. And I would put myself in their shoes. I would say, it's got to be really scary when you feel like your small business that you've worked so hard on is jeopardized or is going under. And so when I took that approach, I learned that they were a bit more receptive. And I was like, oh my gosh, what can we do? What do you need? And I actually put together a resource sheet for kind of more so our small businesses, the vape shops, and stuff like that, that had free business mentoring in the county, at the state level, and then at a federal level, grant programs that were available. And I just felt like maybe giving them a few more extra resources, not just like, sorry, can't help you. Like here's some things you could do. You could, seek out free business mentoring. When I took that approach, when I worked with them, they were a bit more receptive. And a lot of them agreed. They're like, yeah, this stuff is bad. I see so many kids out vaping. Like, I don't want them to be using this. So yes and no. Some are receptive and some are not. What's interesting is that the county flavor ban passed in January, and then another local jurisdiction passed a flavor ban that actually just went into effect in July. So as far as implementation goes and seeing if there is a high compliance rate with COVID, we haven't been able to do enforcement checks, so we don't know yet. When it's safe, I'll start going out with some of the officers and doing those enforcement checks. We're not going to cite anyone right off the bat. We intend to just go out and, again, provide more education. So I'll be interested to see what that looks like given this environment right now. So I hope that answers the question.
Yes, it did. Thank you so much for sharing that. And so our next question, and I'll just go back to you, Megan, being a recent graduate of the program, did you have a favorite community health promotion professor or course while enrolled in the program?
I don't want to say I had a favorite professor because I really just loved all of them. As far as courses, I find myself reaching for my foundations. Is like Foundations in Health Education, I think, book, and looking up some of that more foundational stuff when I want to touch on it. A lot of the theories of behavior change I like to reference a lot and just kind of think about when I'm working on educational materials. I really loved communication in public health when it comes to doing more of the social media or paid media stuff. I think about my program design and evaluation class as I'm working on our progress report right now. So I don't have a favorite. They were all fun.
Okay. And you know what? I'll say all of the professors are absolutely wonderful. So I thank you for sharing that. So the next question is for Pavana. The question is, in the patients you saw, did you observe a correlation between pre-infection activity levels and COVID patient outcomes?
Activity levels as in exercise is how I'm going to take that. Not necessarily. I think that's hard to kind of judge. Definitely though, I will say obesity seemed to be a risk factor. And I think now it's going more publicized that there have been a lot of cases where patients with obesity have had, a more severe form of COVID. But then there's so many things that we still don't know about this disease that it's really hard to say. A lot of the research has shown, for instance, that diabetes and hypertension definitely increase the risk of a more severe infection. But at the same time, what is the role that obesity plays is unsure. What is the role of, cardiovascular diseases, other underlying problems, genetic conditions? There's just so much we don't know that it's very hard to give a clear-cut answer about this.
Okay, thank you. Our next question is back to Megan. Megan, did you ever get formal training on motivational interviewing, or did you develop your own techniques to talk to tobacco retailers?
Yeah, I think my first experience learning about motivational interviewing was definitely in my Foundations of Health Education. class, and I found that really interesting. And then with everything I learned in the MPH, I actually went on to become certified as a health education specialist. And so to some degree, I received some training, or rather, I think that within the competencies of becoming a health education specialist, we learn about some of the values and practices of motivational interviewing. But I will say, I know that there's far more that can be done, and there's even certifications and stuff in motivational interviewing, and I haven't done any of that work. But I think because I work more on a higher level and focus on policy stuff, it wouldn't be at first glance super relevant to me, but I could also see how potentially, working with any community levels, especially if we were to do cessation services when it came to smoking, motivational interviewing would be really important. But I'd love to do it in the future, but I don't have any formal training at this point now.
Okay, thank you. Thank you for sharing. For the sake of time, I'm going to ask one more question, and this question is actually for the both of you, so dig deep into this, okay? And I'll ask Pavana to answer this question first, and then Megan, you can follow up with your response. So the question is, why did you guys pursue an MPH degree in the first place?
I've been waiting for this question. So for me, I know a lot of people would say, you have a graduate degree, why are you doing this? And, why do you need more education? And I think for me, it's more of a double-pronged response, where the first aspect of it is I've always been very interested in vulnerable communities, especially medically underserved areas. And those are the populations that I really done a lot of work with, even before medical school and throughout medical school. And through my experiences, I really felt that there were so many issues that could be, resolved in a way in terms of decreasing, severe patient complications and, reduced patient outcomes and all of that could be prevented or taught. And I think a lot of those techniques, are what are taught in the MPH program. And I'm really here to learn those techniques and to know, how do I go about implementing these programs that can reduce risk and improve health literacy, kind of like how I talked about before. The second part of it is I am more and more becoming interested in policy work and how do we change this on a more grand scale, not just at a local level, which, while very important in its own right, is very kind of situational. It depends on the team members. It depends on how the team members are interacting with the community and all these environmental factors. How does the community feel about, this work that the, public health office or other governmental or non-governmental organization is doing? And why I think change has to occur at various levels, both at a micro and a macro level. And for me, I want the tools to be able to deal with this at a macro level. And so I think those are the two main things that I'm doing this MPH for.
I will jump in and firstly say that I wish that more physicians in general would get their MPH. So thank you, Pavana. Having this experience now, even if you're working at a larger kind of systems policy level, it's important. And there's so many places for MD, MPH, but even if you're working with individuals, it's really, I think it adds a lot. So thank you. I wish that all of my doctors had their MPH. But speaking for myself, I knew that I wanted to go into healthcare, all kind of throughout undergrad, and I was focused on physical therapy, and I really enjoyed that, mainly because it wasn't just giving medications. I think that's what appealed to me in physical therapy. You saw your patient, at least once a week, maybe 2 to 3 times a week, and you literally worked hands-on with them so frequently, and I really enjoyed that. But kind of as I mentioned, as I learned more about preventative medicine as a whole, I got really interested in how we can implement preventative medicine on a community population level. And now, I learn and I get to implement that kind of preventative action on a policy level. So for me, it comes down to helping people, taking care of people, keeping them healthy. And I think especially right now, working on, health inequities and making sure that everyone has the same access or different access because they need more or stuff like that. Again, there's this equity equality issue, and we want to make healthcare equitable, and we don't want to see these health disparities continue. And so I hope that, with this training and with this kind of new experience I'm gaining, I can take what I've learned and focus it in that direction and just make sure that the people who need to stay healthy are staying healthy. So those are my reasons.
Wonderful. Thank you so much for sharing. And before I conclude, I actually got a comment from one of the doctors that is, on the line as a participant around the support for families of the patients. And it was stated that the palliative care nurses give a whole lot of support to families dealing with, members of their family in the hospital. So thank you so much for sharing that information. I want to thank Dr. Pavana Varanasi and Megan Kinney for sharing their experiences with us today. And I would like to thank each and every one of you who took time out of your schedules to participate in today's webinar. If you have additional questions, and or you're interested in applying to the Master of Public Health Online program, please feel free to reach out to our admissions team. Again, a copy of this presentation will be available in the coming days. Please be sure to follow us on our social media platforms. Our handles are located on the screen right now. This concludes today's webinar. Thank you again for joining us today. Please continue to stay safe and stay healthy, and have a great rest of the day.